Good afternoon, everyone, and thank you for joining us today. My name is Ashley Ring, and I'm the Associate Director of Public Education here at the American Kidney Fund. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to the questions box or out loud during the end of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. As a friendly reminder, for those of you who are health professionals, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. So today's presentation is about depression, which is a commonly overlooked complication of kidney disease, but something very important that we're excited to share with you today. Our Dr. Daniel Suker is an associate professor in the Department of Psychiatry at SUNY Downstate in Brooklyn, New York, where he has the roles of researcher, clinician, and educator. Dr. Suker received his doctorate in clinical health psychology from FERC Health Graduate School. He has a long-standing interest in the psychosocial needs of patients with kidney disease and has written many articles and chapters on the mental health needs of patients with kidney disease. His current projects include depression, pain, sleep, anxiety, and the adherence behaviors of patients with renal disease. We're excited to hear from Dr. Suker today because he specializes in the relationship between kidney disease and mental health. So thank you, Dr. Suker, for joining us, and we're excited to hear your presentation.
Thank you very much, Ashley, for that kind introduction, and welcome everyone. I'm happy to spend the next little bit of time with you guys talking about depression, the overlooked complication of kidney disease, and I'm also very happy to answer your questions. So there will be time at the end of the presentation for questions, so please send them in throughout so that we can address them at the end of today's talk. All right, one moment. So I have no financial conflicts of interest to disclose. And the topic of today, or the outline for today, is about depression. And we're going to be talking about what is depression and really why does it matter? Why do people with CKD or chronic kidney disease have higher rates of depression? How come treatment is so hard to find? And where can I find additional resources? So let's just jump right in. But the first thing that I would like to do today is ask you guys a question just to see who is out there and what's on the mind of the people listening today. So the first question is, there's the poll question. I think the most important psychological issue facing dialysis patients is, and please select one or more of the following: stress, depression, sleep difficulty, or anxiety. Which one do you think is the most important psychological issue? We'll just give it a few more moments, and then we will be able to see the results of what people out there are thinking. Okay, so about 71% of you identified depression, 34% stress, 41% anxiety, and 27% sleep difficulty. So depression is the winner, I guess, of that group. So it's the issue that is most important for people facing most important psychological issue of patients who are on dialysis. That does not take away from the importance of some of the other issues, which is sleep difficulty and anxiety. But I, for one, do agree with the group that depression is the most important of the psychological issues, and I'll spend a few minutes here explaining why. Just waiting for the controls to come back to me, but it's interesting that both anxiety and sleep difficulty, which we will talk about a little bit, are part and parcel of the depression experience very often for a lot of people. And stress is not something which is often talked about. So what is depression? So here's an old definition from 1973. Depression is characterized by feelings of helplessness, hopelessness, inadequacy, and sadness. However, these are symptoms of several disorders and can also occur in normal individuals. So even the definition itself is kind of confusing. We don't know always, if somebody is depressed or not depressed. And sometimes we ourselves might not know if we are depressed or not depressed. And I'll return to that a little bit later in today's talk about how to know for yourself. But part of the issue here is that it's a little more complicated even in patients with renal failure, because there's some overlapping symptoms with depression. So you can see here is these overlapping circles between uremic symptoms and medication side effects and depression. So how do you know if a person is not feeling well? How do they know if they're feeling depressed, or maybe they're just not being appropriately dialyzed, or maybe they're just having some medication side effects? That's a really complicated question. And to go further, what I've done here is I've listed, this is a pretty common measure, self-report measure of depression. It's called the Beck Depression Inventory, and it has 21 questions. And these are just the titles of the questions. But what I've done is I've highlighted in pink the last group, which overlaps with uremia. So if you're just not feeling well, you're going to have, changes in the way that you look, changes in the way that you move. You're not going to be able to sleep well. You're going to be tired, change in the way you eat, loss of weight, right? Concern about your health and your body, and just general low levels of energy. So even while those things might be related to depression, they're also related to uremia. So sometimes it's a bit of a challenge to identify who is really depressed and who is not depressed. But let me change gears for a moment and talk about why it is important that we know who is depressed and who is not. And this is a picture from a dialysis patient who made the dialysis blanket, which is something that she, I believe, gave out to her fellow dialysis shift mates. And I think it's a little tongue-in-cheek, wake me up when it's over, partly about the dialysis shift and maybe partly about dialysis in general, right? It's a really difficult experience to go through. And what we know is that there is an association between being depressed and morbidity, meaning how long you will live. And we will return to that topic in one moment. How many other illnesses you have, what the rates of infection are, how often you get hospitalized, and what your overall quality of life is. And there's all these studies that have been done over the last really 20 years looking at this relationship, and it's a pretty well-documented relationship. And there was this meta-analysis which said that the risk of death is increased by 50% if somebody is depressed, which is a really high number. So I want to kind of continue on that, even though it's a bit of a morbid topic. I do want to focus on it for a moment. And this is a little bit of a complicated slide, but I just want to highlight one thing for you. So this is what we call a survival curve. So at the beginning, I hope you can see where I'm pointing. At the beginning of the study, 100% of the people are alive. That's when we first met them. And we gave them one single depression inventory, just one measure of depression. They filled it out themselves. And then for the next 5 years, we didn't do anything. And then after 5 years, we kind of looked back at those people to see what happened to them and if they were still alive or not alive. And the people that had mild or moderate depression or no depression at all, about 75% of that group was still alive. And that's about what you would expect for people who have end-stage renal disease, given their age and the other medical conditions they might have. But if you look at the depression group, only 40% of that population was still alive. Now, this is not conclusive. This is a small group of patients. It was just one set of observations. We don't know kind of what happened to these people over the course of these 5 years, but this is a pretty strong gap over here, a pretty wide effect between the people that were not depressed and the people that were depressed, what happened to them over the next 5 years. So the big question that I want to think about today or talk about is, how does depression impact the course of their medical illness, of the people in that study, but really our medical illness? How does it how does it go from being something which is just a mental disorder or something kind of, a mood disturbance to being something which really should be of utmost medical concern? So there are two primary ways, and I'm going to spend some time talking about each of these. But if somebody is depressed, they have biological changes in their body, which here on this slide I've marked as allostatic dysregulation, which we will talk more about in a moment. But there's biological changes in their body that lead to more progressive kidney disease. And also, if you're depressed, your compliance might change, right? When you're feeling low, when you're feeling bad, you don't feel like doing anything, even the things that you used to like doing, let alone doing the things that you never liked doing. So if you're feeling depressed, you're not going to be that motivated to watch what you eat, watch how much you drink, to take your medication exactly the way that the doctor wanted to do it. And all of those things can go about leading to, change in your illness. So we're going to talk a little bit about this biological relationship. And this is really just a background slide. So many of us are familiar with the idea of homeostasis, which is that our body requires balance. And there's an idea put forth by Bruce McEwen, who's a scientist, a research scientist in Rockefeller University, of this idea called allostasis, which is like the amount of effort that your body has to go through to maintain that harmonious balance. And this idea of allostatic load is like here at the bottom, the cost to the brain and the body of this continual allostatic response. So how hard does your body have to work to maintain that homeostasis or that balance? And I like pictures. So here's pictures from Dr. McEwen. So this is differences in the effort required for maintaining allostasis. So what you can see here on the left-hand side of the picture of the left side is that there's, a 5-kilogram person sitting on this side of the seesaw. And what that's supposed to represent is how much stress there is in that person's life. So there's a small amount of stress. So the body has to mount on the other side a commensurate or an equal amount of response to deal with that amount of stress to maintain that homeostasis. But then on this side, if there's a 500-kilogram amount of stress, so the body has to put 500 kilograms of effort into maintaining that balance. So even though the person from the outside might look like everything is balanced, they don't see inside how hard that person has to work to maintain that balance. And if you look a little closer, you can kind of see that this is not really straining the seesaw, or that balance is kind of functional on the left-hand side. But on this right-hand side, there is strain on both sides. The amount of stress that this person is under is really very heavy, and the amount of effort that is required to just cope and to deal with it is a extended amount of effort. So even though there's balance, there's strain on this system from both sides. So another way of kind of putting this in perspective is if you have a kind of regular person who is experiencing all of the regular strains of normal life existence. And for most people, without ESRD, they're doing all they can to just cope and to do the best that they can to get on in life. And then what happens is you dump upon them all of this stress related to being a dialysis patient. So there's changes in the way they feel, there's changes in their family, there's changes in now what they have to eat, in their time, what they can do, their ability to make money, all these new people in their lives, all these changes that are going on, and possibly an awareness of impending death. So all of that is really stressful. So what happens is this person who has been kind of functional or doing pretty well, all of a sudden now is getting all of this extra stress upon them, and they have this great demand of this large sumo wrestler size of stress weighing down upon them, and it forces them to mount a response which is commensurate to that. And that is really challenging, especially given if you're not feeling well and you're not coping at your best and you're tired and fatigued, dealing with all of the extra challenges of life that are there. So I think that really helps us transition and understand pretty well, why are people with end-stage renal disease at higher risk for depression? So, here's the full picture of it. So you have on the right-hand side in red all these extra stresses that are going on for the person, and then they get interpreted or they get, filtered by the green things, right? This person's culture, where do they come from? Their personality, their psychological functioning, their social support, the amount of support that they have in their lives. And then that all gets filtered through and reaches the patient. So it's, a very unique experience for lots of dialysis patients. Just because you're on dialysis doesn't mean you're experiencing it the same way as other people. For some people, certain parts of it are really challenging and other parts of it are okay. And for other people, it's just the opposite. And for some people, the whole thing is kind of overwhelming and demanding. So all of that has to do not only with the stressor, but kind of with this green column as well of what else does that person have? And this is true, obviously, not only for people who are on dialysis. This is true for everybody who has stress in their life, which I think is everybody. But these are just the added stresses that are in people's lives above and beyond the normal stress of being a regular person. So, over the course of my career, I've had the opportunity to work with a lot of people who have been depressed, who are on dialysis. And actually, a lot of the time, most of the discussion is not really about dialysis-specific stresses. It's just the compounding effect, the addition of this to their marriage, to their financial struggles, to all the other things that people not on dialysis, are wrestling with. So it's that plus all of this dialysis stuff that really just becomes overwhelming for many people. So this is a slide that I collected some data here in Brooklyn. That's where I am. So just asking everybody that we could, which was 70 people who agreed to answer our questions, what kinds of problems are you experiencing right now? So 30% of our population had no psychiatric diagnosis, and 70% had some psychiatric diagnosis. And if you look more carefully, we broke it down over here, about 35% of the people had depression. If you look at anxiety at this red line, about 22% or 23% had anxiety, and then a smaller percent had problems with use of drugs and alcohol, and then a smaller percent had problems with psychosis. And I have this extra half of the anxiety pillar here. Some of you might be curious about. So those are what we call simple or specific phobias. So a lot of people in this world are afraid of things like spiders, bugs, or rats here in Brooklyn. So if you have a simple phobia, that counts as an anxiety disorder, but in our mind, that's really not that pathological. It's kind of pretty commonplace, so we draw a line there to not really count this top half. But between depression and anxiety, you're talking about more than 50% of the people are struggling with those issues. So there's two different theories that I'd like to talk about as to why people become depressed. The first one is from Beck, who's still alive. He's a psychiatrist, and he has this theory, which is the basis for cognitive behavioral therapy, which is that if you believe that the bad things in your life are internal, which means that they're because of you, they're global, which means that they expand all throughout all domains of your life, and stable, which means that they're not likely to change. So that's a hallmark of depressive thinking. People that have those types of thoughts are at risk for developing depression. And I have a little example here. So if somebody was late for dialysis, on the top here, if they have this thought that I was late to dialysis because I'm a lazy person, it's about me. I'm always late for treatment, right? It's pretty global. And that the care team is going to be mad at me. There'll be consequences. It'll be in the future. I am not doing well on dialysis. If that person has that belief, yeah, they're probably going to feel pretty negative about it, pretty bad about that experience. As opposed to the other person who had the same experience, they were late, but they have a different understanding, a different conceptualization. I was late because my son was late to pick me up. I guess I need to find a backup plan for getting in on time. I know if I try hard, I'll be able to make it on time most days each month. So they're not going to be perfect, right? They don't have this expectation that they'll be perfect, but they have this can-do attitude. And that person is much less likely to deal with depression than the first person. There are different pathways that have been identified in the depression literature that are hallmarks of this depressive kind of thinking, or types of thoughts that make you likely or at risk for developing depression. So the first one is what they have termed disconnection and rejection, which is an expectation that one's needs for security, safety, stability, empathy, sharing of feelings, acceptance, and respect will not be met in a predictable manner. And here I have a little cartoon which I think highlights how this might be true for the dialysis patient. Right here, the stewardess is saying, I understand it's your dialysis time, but sir, you may not bring that on the plane. So how secure can you feel in this world if you are so dependent upon the machine, the staff, and everyone? The next one is impaired autonomy. It's your expectations about oneself and the world around them that interfere with one's perceived ability to separate, survive, function independently, or perform successfully. And here is a cartoon, right? It's Santa Claus on December 24th, and the nurse is telling him, I don't care what day it is, 4 hours is 4 hours. So how empowered do we all feel when we are not really in control of our own schedules and our own lives? The next one is impaired limits, which is a deficiency in our internal limits or long-term goal orientation, and it can lead to difficulty in respecting other people's rights, cooperating, or setting and meeting realistic personal goals. So in this one, right, you see the person comes in, the doctor says, and how was your fluid control this weekend, Mr. Johnson? Clearly not too good. The next example is the next type of depressive thinking is overvigilance and inhibition, which is an excessive emphasis on suppressing one's spontaneous feelings, or like meeting a rigid internalized set of rules that one has about themselves, about how they have to perform in order to be happy or to be healthy. And here we have, go ahead, dear, and make a wish. The husband is bought her a cake that she does not appreciate, when in her mind she would like to take that cake and stuff it in his face, but instead she just goes along with it. So we inhibit our intuitive responses. So when that happens, that is a risk for depression. And then there's the last one is this other directedness, which is when we have an excessive focus on the desires and feelings and responses of other people at the expense of our own needs. And here we see two people going into the ice cream shop, and the person saying, of course I will get your favorite ice cream with you. I'll just have to lie to my renal dietitian on Monday. Right? So both this person is unable to stand up to their friend or to say this is not a great healthy choice for me, but instead of really being concerned about the impact on them, they're more concerned about whether the dietitian is going to catch them on Monday, so she's already prepared herself with a lie. So people that experience those types of thought patterns, which I think are really natural to what dialysis breeds in people, are at risk for depression. So it would make sense from that theory or from that perspective why there's such a high risk for depression, in particular for people who are on who are getting treated with dialysis with end-stage renal disease. The second theory that I want to talk about is something called learned helplessness. This is by Marty Seligman, and he did this experiment where there was this box and there was shock grids on the floor, so the dog would get a little shock, and there would be a sound that would happen right before the shock would come. And the dog would very quickly learn that as soon as the sound went off, they would jump to the other side of the box where they wouldn't get a shock. But then he manipulated the experiment a little bit, and it was random whether the shock came with the sound or didn't come with the sound. And what happened is those dogs just lied down and took it. They stopped trying to fight. They didn't jump from side to side. They couldn't figure out the system, and they just would lie down and get shocked. And he termed that learned helplessness, which is this passive behavior produced by exposure to unavoidable aversive events. And I think if we translate that to the dialysis patient, if your typical schedule is you wake up, you prepare for dialysis, then you go to dialysis, and you recover from dialysis, and then you kind of do the same thing, 3 times a week. So the things that make life enjoyable, relationships or fun or achievement oriented or the ability to work, they often fade to gray and they fade to the background. And you're really just focusing on your dialysis care and treatment. So, who wouldn't be depressed? So the way that you think about this learned helplessness model is that if you feel like no matter what you do, it's not going to make a difference anyway, you're not in control of what happens to you, so then why bother trying? And I think that's something that I've heard a lot from people who have been struggling with depression, who are dialysis patients. So I'm not going to talk too much about it, but anxiety is a major component for a lot of people of their kind of challenges of dealing with dialysis. And here I have little funny cartoon, but I think anyone who's been a patient knows the what it feels like, how nerve-wracking it can be to be at the whim of the staff and of people who you may or may not know, and really have your life in their hands can be quite anxiety-provoking. Sleep difficulty. So here's a little cartoon, not about dialysis, but I think if it was dialysis, they could all be while you're at the chair on dialysis, except for that last one, lying in your own bed at night when you can't fall asleep. So I have a particular interest in sleep and how people sleep who are being dialyzed, and whether we can help them kind of get into more healthy patterns of sleep. But there was one study that was done which asked people who were on dialysis, what symptom do you find the most irritating of all of the symptoms that you have for being on dialysis? And the landslide winner was that it disrupts my sleep. We all really appreciate sleep. We need sleep to feel good. We need sleep to feel mentally good, physically good. So when it's being deprived, or when we are not being able to get a good night's sleep, really has a lot of negative consequence on our mood and on our physical functioning. Another area that is very tied into depression as well as the experience of pain, and it goes both ways. The more depressed you are, the more likely you are to be sensitive to that pain, and certainly the more pain you're in, the more likely you are to be depressed. So pain is an important part of the dialysis depression experience, and it needs to be thought of and addressed as well. And then we have the idea of adherence. So going back to that chart that I showed you in the beginning, right? When people are feeling low, they don't really feel like taking their pills the way that they are prescribed. And here's just a little comic, right? We've combined all your medications in one convenient dose. So sometimes the physicians, the healthcare team is not exactly tuned into all of the demands that we are asking of the patient, of all the different kind of ways that we are asking them to change their life and to change their behavior. So it ultimately, for dialysis, becomes a really high ask. It's a very high burdened illness. We ask a lot of the people who are being treated with dialysis. So it is certainly no surprise that when people start to lose their motivation, their adherence in some way or another suffers as a result of it. So social support is really important. And for some people in this world, they experience their family and their ones around them as one big, lovely hug. But for a lot of us, we experience our family and our social support as people pulling us in different directions and very challenging. So sometimes the more people in our lives, the better. Sometimes the more people in our lives, the more problems we have. And then the last thing I wanted to talk about in terms of things that go along with depression is sexuality. So this is the elephant in the room. So there's very little discussion going on between everyone, between the dialysis patient and their spouse, between the dialysis patient and their partner, between the dialysis patient and their physician. And this largely has to do with our own discomfort with talking about sex and sexuality. And until we are able to get past the discomfort that we have in talking about it, we're not really going to be able to address it. But certainly that's part and parcel of the depression presentation for people who are, for all people, and in particular for people who are on dialysis. So now we come to our second poll question. I guess we can turn it over to the people doing the poll. So in regard to my mental health, my treatment team is excellent. All of my needs are being met. Is adequate. My basic needs are being met. Or is poor. My needs are not being met. So the way that I kind of envisioned this question was, if you think about what is being offered at your dialysis center, what additional resources might there be for you? Are your needs being met? Are they meeting your basic needs, or are your needs not really being met? Okay, we can go ahead and close that. Let's see what people thought. So about 65% of the people thought their basic needs are being met, about 20% thought all of their needs are being met, and about 15% thought their needs are not being met. Okay, so I think that has improved over time. I think had we done this 5 years ago, those numbers would have looked quite different. I think there is a growing awareness and appreciation within the dialysis treatment teams and the dialysis treatment community of the importance and the primacy of depression and mental health in general, and therefore they are expending more resources. They're trying a little harder, giving the social workers a bit more time to deal with some of these issues. Okay. I had the opportunity to speak to a large group of nephrologists at the American Society of Nephrology, and I asked them a similar question, which is, how well do you think your centers meet your patients' needs for depression? And this was about maybe 5 years ago, and roughly about 80% of the physicians acknowledged that they weren't doing enough at their center to address depression, and it was a priority for them. And only about 20% thought that it was adequately addressed. So now I'd like to shift gears a little bit and talk about how come it's so hard to find depression care for dialysis patients. So what I will share with you now is a model that I have created called the comprehensive approach to identification and treatment of depression. So first, what you need to do is you need to identify patients with low mood, and then you have to diagnose whether they really have depression. And then you have to do something called stepped care, which is really treat the depression in the appropriate way that it needs to be treated. So if it responds to the first treatment, then great. If it doesn't, then you have to think of a second line treatment and provide it. Do some sort of outcome evaluation, right, to demonstrate, oh yeah, we got the depression under control. And then you have to see if there's other comorbid conditions that you need to treat, other things that are going on for this person. Do they have insomnia still, or did that get better as their depression get better? How about their anxiety, other problems that might go along with the depression? And then finally, after they're all feeling all better, you have to do something called relapse prevention and monitoring. So just because you're feeling good at this moment doesn't mean you're cured. It just means that it's something that you need to keep an eye on in the future to make sure it's not a problem. So this is the model that we use. I treat people outside of the dialysis, treatment centers, people just coming into outpatient psychotherapy. This is kind of the model that is used for treating people with depression. Now, I just want to really briefly go through all the difficulties with this model in the dialysis center. So in terms of identifying patients with low mood, we don't know who's responsible for this task yet. Is it the dialysis centers? Is it the individual patient? We don't know what the best tools are to identify people who really have mental health needs because of some of the things that I talked about in the beginning about the complexity of this diagnosis. We don't know at what degree does follow-up required here. How often should patients be evaluated? And then we move on to the diagnosis of depression. So who does this? Who provides this diagnosis? Do we need a diagnosis before we get into care? Why? Who's going to pay for this evaluation? And then how is this information shared with the treatment team, with the patient, with the social worker? How does that actually get operationalized? And then we move to the treatment component, and we don't know what the optimal treatments for depression are for people with end-stage renal disease, or what happens if they're treatment resistant, if the first thing doesn't work. Do we have no clue what the second line treatment might be? We haven't really thought about who should get prioritized for care. Who's going to provide this treatment? Where will this treatment be offered? Who's going to pay for this treatment? A lot of questions. And then in terms of the outcome evaluation, if the person is done, whose responsibility is that? Is that the dialysis center's responsibility to figure out? Is it the treating physician or the treating psychologists or the social worker's responsibility to figure out whether more treatment is needed? How does this information get shared across the team? Now, again, for the treatment of comorbid conditions, we don't really know how to treat insomnia, anxiety, substance use, or dialysis treatment non-adherence, or dietary non-adherence. All these things are kind of comorbid with depression. There's really very little research done on those things. And then for relapse prevention and monitoring, who's doing that? If you go see somebody in the community, nobody's really doing that. So instead of our comprehensive approach to identification of depression, we have this non-functional approach to identification and treatment of depression in the dialysis center. So not a very optimistic picture, and I think some of these things have begun to change. We have some preliminary answers to some of these things, but just to get an understanding, not from the patient's perspective, but from a systems perspective, why is it so hard to get treatment? It's actually pretty complicated to figure out who's going to take responsibility for all the different parts of this process. So now I'd like to speak for a minute about how does somebody know if they're depressed or not? So I'm going to give you two answers, two ways to think about it. This one might be familiar to you. This is the PHQ-2, or the Patient Health Questionnaire 2-item inventory. And it's very straightforward. Over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless. You score it based upon how many days it's been a problem for you over the last 2 weeks. And according to all of the data that they have collected, if you get over a 2 on this, a 2 or above, then you are likely to be depressed, or maybe a better way to say it is you should be evaluated if you are depressed or not. So it's a way of kind of screening out the people that are certainly not depressed, but perhaps you are depressed if you score a 2 or above. That is the kind of way that most dialysis centers have decided to screen, but I much prefer asking yourself a simple question. Am I getting the most out of life that my physical health will allow? If you say, yes, I'm doing everything that I possibly can given the physical limitations of my life, then great, you're probably not depressed. But if you are not able to do all the things that you think you might be able to do, if there's something holding you back, something getting in the way, that more than likely is probably an element of depression. And if that depression is there, so then it becomes really difficult to kind of ignore, and it ends up growing. So, you know, sometimes when you have the energy and you're feeling good, you'll do some things, but those days seem to come less frequently and they're less reliable. So very often people just, you know, stop making commitments, they stop going out, and you can start kind of thinking about, you know, that learned helplessness model. If you feel like you can't really control it, you can't do any of those things, so then you know, the path to depression then becomes laid out in front of folks. So what kinds of help are out there? And unfortunately, this is the shortest section of my talk, but I will kind of give you an overview of the different types of treatments that are out there. So I think first and foremost, the person that you should turn to is your dialysis social worker. They are the person that is charged with the mental health of your you know, of their constituents, of their patients, and that's who the dialysis centers look to, that's who the nephrologists look to be the liaison between the patient and their mental health needs and, you know, and the team. The problem, as I'm sure we are all well aware, is that social workers are asked to do many different things. There's too many hats that these social workers are wearing, so they have very limited time to really spend you know, quality time working with an individual. And, you know, very often they might have caseloads of 50 patients. And you know, if you have 50 patients that you're responsible for, and, you know, the estimates for depression are around, you know, 30% of the people are depressed. So spending an hour with all of those people is just an impossibility. An hour a week with all those people is just an impossibility. So the demand on the social workers is too high, but that's really where the beginning of this process should be. A second category is what I would call self-help. So you turn to your social network, your friends, your loved ones, the people that care about you. Keeping it to yourself is the worst thing to do. Sharing it with people, trying to marshal whatever resources you might have, that's the way to prevent yourself from digging in deeper. There are many, many books, self-help books, all kinds of books about depression. Those books are available online, they're available in print, they're available everywhere. Religion, so if it is your cup of tea, you know, getting engaged with your church or whatever your religious community is, very often serves as a really rich emotional resource for people. And, you know, it's one of the recommendations that I make to people is that, you know, if you are religious, to get involved or kind of recommit to your group, because, they will follow you. And if you say, I'm not in the mood today, they'll say, come on, come down anyway. We're doing a event, and it kind of drags you in. So it overcomes some of the depressive resistance that people feel towards getting out there and doing activities. Another good thing to try is exercise, although certainly complicated for folks that have renal failure and many of the comorbidities. A lot of people have cardiovascular problems or diabetes, so it can be hard to do exercise, but getting out there and moving has a pretty reliable effect, makes people feel better. And then there's like self-help groups that are out there, non-professionally run, and they're online. There's Facebook groups for people to talk about their mood and dialysis, and there's also groups in person, I think, often organized by dialysis centers. And then the third category of types of help that are out there are professional help, and there's really two, for depression in general, there's two primary types of depression treatment available. There's medication and there's psychotherapy, and I have listed here just a resource that you can use. So the first one is from the American Psychiatric Association, and it's just a list of all the psychiatrists and I believe what insurances they accept, searchable by zip code. And then the second one is a free service from Psychology Today, which is a magazine. You can look up every therapist, what they charge, what insurance they accept, their bio, whatever information you would like, and these are both national databases. So the two different types of help that are out there are both medication and psychotherapy, and in particular within psychotherapy there's a particular type of psychotherapy which is really effective for depression called cognitive behavioral therapy. And I would like to end our discussion today with a little cartoon vignette of a real patient that I saw using cognitive behavioral therapy, just to give you a sense of what that was like. So here's my gentleman was on dialysis, and I came and was talking to him while he was on dialysis, and he said, all I did was go to dialysis today. What a waste of a day. And then I just questioned, why is going to dialysis a waste of a day, just to see what he would say to that. And his response was, if I can't provide for my family, what kind of man am I? And I said, that's a good question. What value would you have as a man if you weren't making money? So none is what he said. I'm now completely useless. And that really struck a chord with me. And I said, wow, I could really see how anybody who thought they were completely useless would be feeling very depressed. So in essence, this person had gone from being a vibrant, contributor to his family, patriarch of his home, wife and kids. And now he didn't know what his role on this world was. And he basically was waiting to die, as he said, because he had totally lost his sense of where he belonged and what he wanted to do. So then I challenged him a bit. I said, but is that true? Are you actually useless if you don't make money? What are some of the other ways you do or could contribute to your family aside from just dollars? So this makes it seem easy, but after some time, he kind of came up with some ideas. And he said, I guess I could help my wife more around the house. I could reach out to my kids and see how they were doing. And I said, yeah, you just might need to adjust what you think being a man means. And you never know, your family might like the new you. And in fact, I'll share with you that, what we do is something called the behavioral experiment, which is you don't really believe that what we're about to do is going to work, but let's try. So I got him to agree to try. I said, instead of your wife coming home every day from work, she had to return to work because her husband was no longer able to work. So instead of her coming home every day to find you lying on the couch, watching television, waiting for her to come home and make you dinner, what do you think she would do if when she came home, dinner was waiting for her on the table? And he said, I don't know, because in all my years of marriage, I've never done that for her. And I said, well, let's go ahead and try. So he tried, and he called his sister, and he tried to make some food. He had never really been much of a cook. So he made food, and his wife came home, and she saw that he had cleaned up a little bit, and he had made dinner, and there was a candle burning sitting on their table. And first, she was extremely skeptical. She thought something was dramatically wrong with him, that he had gotten some bad news from the doctor or something. But then after he assured her, he said he wanted to see if I was right, is what he told her, and that whether this would make a difference. And she told him it would make a big difference if she came home every day and had dinner waiting for her on the table. She could see that he was trying, and she could see that he was really putting an effort in. And even though that dinner was not edible, as he describes it, they both enjoyed it very much. So I just want to end with a last poll question here. And the question is, if I needed to receive treatment for my depression, my preferred way of getting that treatment would be, and select one of the following. Would you like to get medication from a psychiatrist, someone not part of your regular treatment team, but somebody who's a mental health specialist? Medication from my nephrologist, so someone part of your regular dialysis care team could write this prescription. Or if you would prefer counseling, would you prefer counseling done chairside during dialysis, so the therapist coming to see you at the dialysis center and talking to you next to you? Or would you prefer counseling done through telehealth or like video chat, so you get a computer or some iPad while you're being dialyzed and you can kind of patch in and talk to someone live one-on-one who would serve as your therapist, but not actually be there in the room with you? So you can go ahead and vote. Okay. So it seems like therapy is preferred over medication. And the idea of doing a chairside seems palatable to people, maybe a little less palatable to do it through telehealth. And then if you wanted to get medication, although not enthusiastically, people would like to get it from their nephrologist slightly more than from their psychiatrist. Okay, thank you. So that is the end of the formal part of this presentation. I want to thank you all for your attention, and I look forward to hearing some of your questions and weighing in on them.
Thank you, Dr. Suker. We really enjoyed your webinar. It was very informative. I know I learned a lot, and I'm sure that our audience did too. So thank you so much. As a reminder for everyone, before we get started with the questions, our slides that were used today during the presentation will be posted to our website once the recording is made available. It should be posted to the website within 1 to 2 weeks. So check back at kidneyfund.org/webinars for this information to be posted. So at this time, Dr. Suker, I'd like to go ahead and ask you questions that we have been receiving throughout the presentation. And everyone, please continue writing in your questions. I will say, since we only have about 10 to 12 minutes to answer the questions, if we don't get to your question today, we're going to put together those questions that we'll share so that Dr. Suker can answer them afterwards. And we'll share those on the website as well if we don't get to your question. Okay, so I'm going to dive right in. So someone said that they see a lot of patients that give up on being their own advocate as far as their care goes. What would you recommend to encourage people?
So, I mean, I see that as well. And we know that there's a lot of research across all different types of illnesses that what they call either empowered or engaged patients actually do a lot better. So just kind of going with this flow is often not the best way to get the best care, but really being a very active consumer, an educated consumer really does help. So if, you know, I guess implied from the question is that if people have given up, it sounds like to me some of that learned helplessness, that people feel like no matter what they try, it doesn't really make a difference anyway. And this does require a tremendous amount of effort to just, you know, kind of exist as a dialysis patient, let alone to advocate for yourself. But what I would try to do with folks is I would try to get them to appreciate, you know, what are the more important decisions that they're facing now? What are the greatest hindrances to their health? And maybe they should prioritize those things and work towards it. And very often something seems like a really large task. It's so daunting because it's a really long-term process, like, I don't know, say getting listed for a transplant or getting on the transplant list. there's so many steps, it's so overwhelming that people will just say, oh, forget it, I can't do it. So, breaking that down into small steps and say, okay, the overall goal is to get on that list. Here are the things that we need to do. You need to go make an appointment with a cardiologist. You need to go get this test done. You need to get that test done. And if you do it step by step, right, you'll get there. And, if you don't do it step by step, if you're not doing it, you'll never get there. So helping people break it down into small steps and then just kind of keep their eye on the prize. That's first suggestion. And second suggestion is very often people do not take advantage of the resources that are available to them. That might be the professional resources, the staff that's available to them, or the kind of personal resources, their family members. Most people in this field, in the care field, really want to help their patients as much as they can, and they just don't know, what kind of help would be meaningful to them. So they might not know why you're stuck in a particular spot. But if you go in and you say, here's my issue, I don't know what the next thing is, they might point you in the right direction. They might give you some help. And if you're really feeling lost, reaching out to a family member or a friend and say, this is what I really want to do. I don't know that I have the energy to do it, or I don't know how to do it. Would you be able to help me do this? So very often that's pretty motivating to get somebody on the task, to help you have a partner in your goals.
Thank you. That's a really great answer, very thorough. Next question, does the dialysis treatment actually cause changes in the brain that can cause depression?
Excellent question. I think the honest answer is we have no idea. It could be. What we do know, it doesn't seem to be true, but it certainly could be. So there was a large study done, not about depression, called the FHN, or the Frequent Hemodialysis Network, where they did they did more frequent dialysis, and they thought that, I think they did it 4 or 5 times a week instead of 3 times a week. And they wanted to see if there were changes in, lots of different parameters. And one of them that they looked at is depression, and it did not seem to have an impact on depression. And, we do see a boost in depression scores when people get a transplant, but that's probably not biological, in that their kidney functioning is somehow impacting their like neurological or psychiatric functioning. It's probably just because the demands of the illness have been lifted somewhat, and you have more of your life under your control. That's my understanding, but the real answer is we're not really sure. Right,
that would be very interesting to research more about. So someone seems like they probably work in a dialysis center. She said, we use the PHQ-9 to measure depression, but I don't think it's the best tool for renal patients. Do you have a recommendation on what would be the best tool to use because of the physical issues that affect renal patients?
That's a great question, and something that I've actually thought a lot about. And the problem, so the question is correct in that there are physical symptoms of depression mixed in on the PHQ-9, but I do think that, first of all questionnaires that measure depression include some amount of physical symptomatology as well, but that's because people who are depressed have physical symptoms. So the question then becomes, everybody, let's say, is tired who is on dialysis, but are people who are on dialysis that are depressed, are they more tired than people who are on dialysis who are not depressed? And the answer to that question seems to be yes. So there seems to be, even though the baseline might be a little higher for some of those kind of somatic complaints, so the ones that are related to your body or your health, they are elevated. They're extra elevated in people who are depressed. So one of the tools that I use frequently is this Beck depression inventory, and what we do is, so typically if you give it to somebody in the community, the score of 10 or above would be considered depressed. And what we do for people who are at our dialysis center, we consider a score of 14 or 15 or above to be depressed. You kind of get some extra points in there for the fatigue and the insomnia, which are so common to everybody. But with that being said, there really isn't enough data that's out there. So it seems like a lot of the dialysis centers are using the PHQ. It's the kind of one that is in vogue now. So I actually think that it will, in the next few years, we'll have a tremendous amount of data and we will know a lot more. So I love the idea actually that they've picked a particular instrument, with whether it's the best one or not doesn't seem to really matter that much because they're all pretty similar. But we will have a much clearer picture over the next, let's say, 5 years over what the natural course of depression is for dialysis patients. So, now that we're going to have multiple measurements on each person, or we're going to see different courses of the illness over time based upon the PHQ. So I think that all of this will be very informative to how we should target care.
Right, thank you. Well, we have many more questions coming in, so we definitely are going to need to post some of those on our page once this is over. Someone asked if you have any resources for patients with PTSD.
It depends. There is a national association of PTSD. There's a PTSD Center for Treatment and Research that's run through the Boston VA, and they have a great website that has links to people that do treatment all over the country. Another website that is really good is the ADAA.org, or the Anxiety Disorder Association of America, and they have a lot of information about anxiety disorders, PTSD, and also where to get treatment. And there's another website called ABCT, or the Association for Behavioral and Cognitive Therapy.org, and they also have a lot of information about different psychological challenges and a directory of people who might be specialists in treating PTSD.
Thank you. Thanks so much. Do you have any statistics about the differences in some of these things by race and gender, specifically from the statistics that you shared from your clinic or elsewhere?
So that is subject of serious scientific inquiry. So what we do know is that in the general population, women, I'll do the gender issue first. Women present more frequently with depression than men do, and they seem to have depression more frequently than men do. So there's two separate issues. One is they present more, and two is they might actually have it more. That gender divide seems to be less true in dialysis patients. It seems to be more evenly split, so that equal amounts of men and women are dealing with depression. And I think that might have to do with the overwhelming burden to the life limitations that it places. It seems to interfere with your life regardless of what your life was like beforehand, whether you were doing stereotypically masculine or feminine roles beforehand. So I think that explains some of it. So the rates are, I guess, relatively higher for men, but they're really just equal to women in the dialysis population. And in terms of race, we don't really have great data on that. So what we do know is that there was a large international study called the DOPS that was done, and they found rates of depression to be relatively consistent for dialysis patients all across the, I don't remember, 20 countries that they surveyed all around the globe. And it kind of generally matches, the rate that they have for depression in those countries, for the baseline rates in the general population. So obviously it's higher for people who are on dialysis, but it kind of varies in the same way. So countries that have a lot of depression, their dialysis patients have more depression. Countries that have less depression, they have less. What I can say about, so I work in an underserved community. A lot of the patients, a great majority of them are African American here, so there is just, and poor, so those things kind of overlap in my population, and they do serve as barriers to treatment and barriers to care. So I don't know if the depression that's experienced is all that different, but I do know that, based upon your insurance, based upon how readily you can get care, social stigma, resources available within the communities themselves, getting into appropriate care is much harder in certain neighborhoods and certain communities than it is in other communities.
Thank you. So we have time really for one more question, and if you can keep it as brief as possible, that would be great. But it is a big question. So How can patients and professionals overcome the stigma relating to mental illness so more people will obtain services?
Well, the joke that I always tell is I spend half of my time convincing patients that depression is real and they should get treatment, and I spend the other half of my time convincing nephrologists that depression is real and that patients should get treatment. So I do think that patient advocacy has a tremendous role here, and that patient leaders speaking out about mental health and speaking out about demanding mental health resources being provided and creating dialogue around it would be, ultimately the way to partner with patients and with providers to help reduce some of the stigma that is there.
Thank you so much, Dr. Suker. This really was a very informative and excellent webinar. We definitely are going to do more on this topic because clearly it resonates very well with so many people in the kidney disease world, and so we really appreciate you doing this today. As I said before, we will definitely upload the answers to the rest of these questions, probably through a PowerPoint, and we will upload that to our website once we post the recording and the presentation today. Thank you again, Dr. Suker.
You're very welcome.
So our next webinar will be held on June 22nd from 1 to 2 p.m. and we'll discuss the importance of managing phosphorus when you have kidney disease. So registration is now available. So check back at kidneyfund.org/webinars for more information and to register. And when the webinar closes today, please don't close your browser window. You will see a pop-up that says that the webinar has ended, so please close that pop-up and proceed to the webinar evaluation survey. We really appreciate you taking this survey, and your honest feedback will help us make our webinar program even better. So thank you again for everyone that joined us today, and we'll see you soon. Bye-bye.